Indications. The procedure is indicated for chronic plantar fasciitis unresponsive to conservative therapy. After appropriate anesthesia has been achieved, the patient is prepped and draped in the usual sterile manner. The foot is exsanguinated with an S-mark bandage. Hemostasis is achieved with an ankle tourniquet inflated as per the surgeon's predetermination. The surgeon palpates the medial tuberosity of the calcaneus plantar medially. Then, going 1 centimeter distal from that point, a 1 centimeter vertical incision is made. A marking pen is utilized to outline the incision. Using a 15 blade, a 1 centimeter vertical incision is made at the medial aspect of the heel, just distal to the origin of the medial band of the plantar fascia. The incision starts 1 centimeter from the plantar aspect of the heel and ends well below the neurovascular bundle. Utilizing a small curved Metzenbaum scissor, the incision is deepened to start a plane under the plantar fascia and dorsal to the subcutaneous tissue. The tissue locator is then used to extend the plane across the lateral aspect of the plantar fascia. It is important to maintain the plane parallel to the plantar aspect of the foot. The medial band of the plantar fascia is easily palpated with the instrumentation in order to determine the medial aspect of the fascia. The fascia separator is then introduced in order to isolate the plantar fascia between the subcutaneous tissue and the first layer of intrinsic muscle. The fascia separator has an upper and lower prong separated by a 5 millimeter gap. The lower prong extends approximately 1/2 inch further than the upper prong to allow for initial palpation of the underside of the fascia before introduction and capture of the plantar fascia. After removal of the separator, the IsoGuard device is then introduced and positioned securely around the plantar fascia using the same palpation technique used previously with the tissue locator and fascia separator. The IsoGuard design allows for isolation of the plantar fascia and protects the surrounding soft tissue structures from damage during the procedure. The longer lower prong of the IsoGuard is plantar to the fascia and the short upper prong is dorsal. The IsoGuard has a slotted channel extending through the handle and passing throughout the length of the device, allowing the passage of the blade while incising only the enclosed fascia. Both sides of the calibrated cutting blade shaft are marked with 1/2 centimeter increments. They are used as a reference point to the top end of the IsoGuard handle when the blade is placed on the bottom of the foot in the position needed to make the desired length of cut. The surgeon can predetermine the appropriate cut of the plantar fascia, cutting 1/3 to 1/2 of the fascia. In this case, the surgeon prefers to cut 1/2 of the plantar fascia. The surgeon can also use a surgical marker to designate the point of the blade shaft that represents the amount of desired cut to be made when inserted into the IsoGuard. The blade is then placed into the IsoGuard and pushed toward the lateral aspect of the foot. The foot is dorsiflexed in order to place tension on the plantar fascia, and the blade is inserted until it reaches the previously determined calibrated mark. The surgeon can feel resistance while the plantar fascia is being incised. The surgeon can then verify the cut by reinserting the blade without feeling resistance. The IsoGuard and blade are then removed. Prior to closing the incision, the tissue locator can be reintroduced to palpate and ensure that the appropriate amount of fascia has been cut. After irrigation of the surgical wound, the incision is closed with 1 or 2 simple interrupted sutures. The surgeon's preference in this case is to inject a small amount of dexamethasone phosphate into the surgical site. The foot is then dressed with a betadine compression dressing or with a compression dressing of the surgeon's choice.